Good afternoon, everyone. Thanks so much for joining today's webinar. We are very excited to present the NOHep Fight for Elimination. My name is Kate Morales, and I'm the Senior Program Director at the Hepatitis B Foundation and Director of Hep United. Today, we'll be talking about the Global Hepatitis Elimination Campaign and hear from organizations working locally to eliminate hepatitis B and C. So before we get started, just to review a few housekeeping items to let you know how to participate in today's webinar. Please note that all attendees are in listen-only mode, and you will be muted during the presentation. There is a phone-in option, and the call-in numbers are below. Finally, you may submit questions in writing during the presentation by typing them in the question box on your GoToWebinar panel. We'll be reviewing them as they come in, and we'll hold questions and answers at the end of all the presentations. Today's webinar is being presented by Hep United and the National Viral Hepatitis Roundtable. Hep United was founded in 2012 by the Hepatitis B Foundation and the Association of Asian Pacific Community Health Organizations. We're a national coalition of over 35 organizations across 18 states and the District of Columbia. Our mission is to reduce the health disparities associated with hepatitis B by increasing awareness, screening, vaccination, and linkage to care for high-risk communities. Members of Hep United's community-based coalitions comprise of stakeholders from a variety of sectors, include health clinics, health departments, social service organizations, and academic research institutes, among others. They also serve as a voice for Hep B advocacy locally and nationally. And here is snapshot of some of the programs that we have around capacity building in partnership with the CDC, including education and training, capacity development, resource dissemination, and technical assistance. And I will now turn it over to my colleague and co-moderator, Tina Broder from NVHR.
Thank you so much, Kate. My name is Tina Broder. I'm the Interim Executive Director of the National Viral Hepatitis Roundtable, known as NVHR. We're incredibly pleased for the opportunity to co-host and participate in today's webinar. NVHR is a national coalition consisting of community groups, advocates, clinicians, patients, and other government and industry partners. We're working together to eliminate hepatitis B and C in the United States toward a vision of a healthier world without hepatitis B and C. Next slide. Very briefly, some of our policy priorities are to advocate at the federal and state levels for increased access to hepatitis B and C prevention, testing, treatment, and care. We recently published a significant report in partnership with Harvard Law documenting access to hepatitis C treatment across all 50 state Medicaid programs, as well as DC and Puerto Rico. We also advocate for lifting restrictions on treatment in the criminal justice system, expanding access to syringe services programs to link people who use drugs to appropriate Hep B and C screening, testing, and treatment. We advocate in partnership with many others in the U.S. to increase funding to the CDC to better coordinate with community groups on the ground to implement screening and prevention programs and conduct surveillance efforts via the Viral Hepatitis Prevention Coordinator Program. We also fight to protect Medicaid and the Affordable Care Act and urge states to expand Medicaid where needed. Next slide. NVHR also has a program department focused on hepatitis C. We provide capacity building and technical assistance to community-based groups, as well as templates and support for implementing routine screening in healthcare settings. We provide a variety of educational webinars, fact sheets, online resources. We coordinate several working groups for Hep C treaters and for pharmacists. We recently launched an initiative talking about hepatitis C in the context of all of the other health manifestations beyond the liver. We serve as a community stakeholder in a couple of PCORI research studies, and we also provide mini grants to community groups. Next slide. It's now my pleasure to introduce today's panelists. We have quite a lineup. Our first speaker will be Dr. Sue Wong. She's the Executive Board Member of the Americas region for the World Hepatitis Alliance and Medical Director for the Center for Asian Health at St. Barnabas Medical Center. She'll be followed by Tara Farrell. She's the Head of Communications at the World Hepatitis Alliance. Then we'll hear from Heather Lusk. She's the Co-Director of Hep Free Hawaii and the Executive Director of the CHOW Project. Heather is also the Acting Chair of NVHR's Steering Committee. And finally, we'll hear from Lisa Townshend. She's the Clinical Manager of Liver Disease and Hepatitis Program at the Alaska Native Tribal Health Consortium, and she's been with the consortium's Liver Disease and Hepatitis Program for 11 years. I'll now turn it over to Sue.
Great, thank you, everybody. Glad to be on this call. Let me see if I can get my webcam going so you guys can see me. And really happy to be able to talk about what the World Hepatitis Alliance does and this NOHep movement, which we have launched, but really hope that everybody in the world really feels like a stakeholder in this movement. And that's what we really need to get this to really fix a lot of the inequities that we see in viral hepatitis. All right, next. Next slide. Okay. So the World Hepatitis Alliance is an international patient-based, community-based organization. Currently, we have 258 members and in 86 countries, and we are always looking to add new members. So if you're an organization that does a lot of hepatitis work, but not yet one of our members, I encourage you to go on our website and take a look at our membership application. Next. So I think this history is really interesting. We celebrated our 10-year anniversary last year, and a lot of us who've been doing work in the field kind of remember when the first World Hepatitis Day happened, but we don't know a lot of the history in terms of you know, how it is that that we're doing some of the things that we're doing now. So, and I think this also just shows you what important role a community has in a lot of pushing the policies that are really important. So in 2007, the World Hepatitis Alliance was founded by a number of community members and patients. They, as a community, led the first World Hepatitis Day, but it was really just a community event at that point. They pushed for viral hepatitis to be on the WHO agenda. And then really remarkable that they were able to get the first resolution in WHO to adopt World Hepatitis Day as its first official day. And there are only like, I think, 7 or 8 official days that WHO recognizes, such as HIV Day, TB, it might even be fewer than that. Tara can correct me. So in 2011, WHO launched the first official World Hepatitis Day, which many of us in the community remember celebrating at that time. And then in 2012, we launched with WHO the Framework for Global Action on Viral Hepatitis. And there are several other reports that followed after that. And I think all of that is really important to show that that is what led up to what we have now, which is the adoption of the Elimination Plan. So 2015, there was a World Hepatitis Summit. That's the first ever. We had another one last year in Sao Paulo. And in 2016, the World Health Assembly endorsed the Global Health Sector Strategy on Viral Hepatitis. And that is where all the countries that are part of WHO have committed to the elimination of viral hepatitis as its goal for WHO. So as part of that, WHO launched NOHep to be kind of the response to this commitment on the policy level. The NOHep is the community response in terms of us, everybody else mobilizing behind these goals to make sure that it actually happens. All right, next. So 194 countries of WHO are on board, but at this time we only have 9 countries on track to reach the 2030 goal. And some of those countries include Brazil, Egypt, Iceland, but the US is not one of these countries. Next. All right, so why advocacy? We have the political commitment. We have a lot of the medical knowledge, and we have a lot of the tools, such as medications and vaccinations, but we now really need to ensure implementation for making elimination a reality. And we feel like that advocacy voice and it really helps with moving political will and resources to make sure elimination actually happens. So in 2015, as I mentioned, combating hepatitis became a goal as part of these SDGs, which is Sustainable Development Goals that WHO adopted. And in 2016, the WHO committed to eliminating, and we really like that language. It's a very strong language in terms of eliminating hepatitis as a public health threat by 2030, and in the context of universal health coverage. Next. And I'm going to pass it over to Tara. She's going to talk more about the NOHep movement, and I hope all of you guys who are listening become NOHep activists, as we say it, because we really need you all to help move the movement along. Thank you.
Thank you, Sue. Hello, everybody. My name is Tara Farrell, and I'm Head of Communications here at the World Hepatitis Alliance. A massive thank you to NVHR and Hep United for inviting me onto this webinar and for really giving the platform to NOHep, and to be able to, and we're really excited to be able to share more further information about it and to illustrate ways that you can get involved. So as Sue said, really 2016 was really the changing point for us, and it was the moment when 194 goals agreed to eliminate viral hepatitis. And what that meant was agreeing to reach a set of prevention and treatment targets, which if reached will reduce annual deaths by 65% globally and increase treatment to 80%, saving 10 million lives by 2030. So with vaccines and effective treatments for hepatitis B and a cure for hepatitis C available, the elimination of viral hepatitis is both feasible and achievable. The only thing really, well, there's many things, but one of the main things standing in our way is widespread political action. And that's where NOHep comes in. And as Sue mentioned, really what we wanted to do was to create a unifier, something where we can get people, all stakeholders behind it. Sorry, can we go to the next slide? I just don't seem to be able to. Brilliant. So recognizing that action won't be achieved in silos, we launched NOHep in 2016 as a multi-stakeholder movement aimed at driving action to meet these 2030 goals, be it through awareness raising, advocacy, national policy level, prevention activities. And as you can see here, NOHep was established as an independent movement. We, as the World Hepatitis Alliance, act as secretariat, but it is led and developed by a working group who is made up of the World Health Organization, the Centre for Disease Control, CEVHAP, which is the Coalition for the Eradication of Viral Hepatitis in Asia Pacific, ELPA, the European Liver Patient Association, and ourselves. And together over the last 2 years, we have worked closely driving it and building it and responding to an ever-changing landscape. Next slide, please. So as mentioned, it has been developed to coincide with the elimination targets, and therefore our ultimate goal is to be seen as a global platform that can drive action to meet these. And often when people ask me, you know, what do you really want out of NOHep? What would you like NOHep to do? Beyond eliminating hepatitis, what I really think it needs to become is to be seen as something like the red ribbon in HIV/AIDS, and see it as something that all stakeholders, independent of what you do, as long as you're working in the hepatitis community and you're involved and you support the elimination goal, it's a symbol or a brand. So hence why what we want to achieve over the next couple of years is for NOHep to grow and develop so that it becomes that unifier symbol of elimination. Next slide, please. So what does NOHep do? Besides unifying the hepatitis community, it drives this conversation about elimination online. It provides tools and resources to support advocacy, and it gives groups across the world to use a platform to support their aims, share their voice, and be able to connect with others that are doing really well. And that's something that, you know, really is at the heart of NOHep. It is a community, and you know, its success over the last couple of years has been really based on people and their ability to be able to use it creatively to support their own national activities and local activities. And really overall, the whole sentiment of it, it should inspire people to really speak out and really put that positive spin on elimination, because it is a positive story to tell, and that's what really NOHep is trying to do. Next slide, please. So, since NOHep was launched on World Hepatitis Day in 2016, it has really gone from strength to strength. Today, we have presence in over 100 countries, reach millions of people online, and secure the endorsement of medical professionals, ministries of health, governments. And that's really interesting because it shows that there is appetite out there, and there is that fervor to be involved in something that is driving towards a goal. And it continues to give all stakeholders really a platform to connect and share activities, which I'll go into in more detail. Next slide, please. So really to drive this impact, NOHep implements a series of activities which focuses on key stakeholder groups, which are best placed to drive action on the elimination of viral hepatitis. And I'll go through a couple of these programs. And just to caveat that, although despite these being global programs, they're put in place to allow other groups, be it civil society groups or medical professionals or, local governments, to be able to use it to their own national priorities. And that's a really key thing to stress, because often global campaigns can feel quite isolated. But ideally, the way that this has been set up allows people to connect and be able to use it and adapt it to their own national activities. So our flagship program is the NOHep Visionary Program, and we launched this actually last year at the International Liver Congress. The NOHep Visionaries Program brings key change makers together and we identified policymakers, so government representative, medical professionals, and civil societies as not the only, but the ones to be strategically focused on to drive action. And we hope that by working together with these groups, we're able to accelerate that action. And what we have, and at the World Hepatitis Summit last year, as Sue mentioned, we actually secured the endorsement of 6 governments for the campaign. And they committed to taking specific actions under the NOHep banner to drive action towards elimination. And we were working with these governments and trying to get others on board to really highlight the different actions that can be taken and the different changes that can be made in governments that can contribute to NOHep. Next slide, please. And a big strand of this program is the NOHep Visionaries Program for medical professionals. So what we've done over the last year is work with medical professionals in across the world, and we've asked them to come on board, and we've launched the program in 3 regions to date. So last year we launched in the European region, and then the Americas region, and most recently we launched in Asia Pacific, and we're launching in September in Africa. And the idea being here is that this is a program for medical professionals who want to become advocates, who are keen to get involved, like Sue here, who wants to take a step out, beyond the clinical work. Very important, but to work with civil society organizations and advocacy in their own right, as it's so important that they're involved with the elimination of viral hepatitis. So as mentioned, we've already launched across 3 regions and have secured endorsement from 300 healthcare professionals who have signed up and want to take part. This program has been spearheaded by a number of visionaries, and these include the likes of Anna Locke, Don Jensen, Nora Troll, to name but a few. And this program not only supports healthcare professionals in their advocacy activity, but also opens up communication channels amongst civil society organizations and themselves. So we're currently working with our steering group of visionaries to produce a set of resources, advocacy guides for healthcare professionals. And what we're doing is we're taking the amazing advocacy activities that our steering group have been involved with over the years and really understanding how these can be developed, that other medical professionals can take part in. So it'll be a global toolkit or a global guide, and we hope that it will be useful and be able to be adapted and further used across different healthcare settings as well. It'll be launched at the Global Hepatitis Summit on the 15th of June, which I'll discuss a little bit further. And really, we see this as an opportunity for civil society and healthcare professionals to really work closely in achieving the 2030 goal. Next slide, please. Lastly, the third strand of our NOHep visionary program really focus on activists and the kind of bedrock of what NOHep is, the civil society organizations. And really what we've seen over the last 2 years, as I mentioned, is different supporters use NOHep in their own ways, and something that we really encourage. And the best thing that we hear, what people come back to say what NOHep means to them, it gives them a platform to share their own, profile their own activities, but also learn from others. And really what is key to the success of NOHep and to activities is the advocacy effort amongst NOHep. So as Sue said, only 9 countries we hear is on track to eliminate hepatitis C by 2030. And what we want to do is to cultivate and garner the expertise and the support amongst the community and drive action to get countries on track. And the way we're doing that is we're producing a global advocacy toolkit to get countries on track. And we're launching this to coincide with the World Health Assembly happening in May. And that will mark 2 years since 194 governments committed to eliminating hepatitis by 2030. It's really important that we continue drumming the beat. And I know at times it can be difficult to think about the global targets and the global activities when you're working so hard at a national level. But I also think it's important that we continue working or, talking with one voice, and elimination is that. So we'd really encourage you to take a look at the advocacy toolkit when it comes out. It might be useful for your own activities, and it might be a useful way to connect with others. And just last thing on that, it's really important over the next couple of years that we continue advocating to our governments. WHO will be launching their framework, their monitoring and evaluation framework, and countries will have to report on their progress over the next kind of year or two. So now is the time where we really can make strides to drive action towards 2030. Next slide, please. So another exciting update from NOHep, and another thing on our calendar, is the Global Hepatitis Summit, which is happening in Toronto in June. And the World Hepatitis Alliance is actually bringing the NOHep Village to the event. And what we're doing is a 3-day interactive space which fosters collaboration between medical professionals and civil society to achieve what I discussed before, really building those links. And what we have done is we're hosting a number of different civil society organizations, and we're showcasing their work, and people are coming from all over the world to showcase their work and how they're doing it. Now, applications for stands have closed, but if you are interested, please do get in touch, and we can see if we can accommodate you. But there's also a civil society discounted rate. And it really is shaping up to be a very interesting event. So if you are interested in getting involved, definitely get in touch with me or the wider team, and we can tell you a little bit more. Thank you very much. Next slide, please. Sorry. Now that you've heard about what we're doing and the different initiatives that's coming up, I'll just give you a quick overview of how you can get involved, besides engaging with the above activities. But I just want to kind of reiterate, although NOHep might be this, as I mentioned, this global community, it's really important that we talk with a consistent message. More action will be done that way. And as I mentioned, you have your own tools, you have your own priorities, but we do offer a full suite of infographics and leaflets and merchandise designs, and if they can be of use, we do really encourage you to go online and download them. And, the NOHep logo, it is building strength amongst governments, amongst the community, amongst medical professionals, different stakeholders. And the more that we use the logo, the more that we can drive action towards elimination. And of course, the Advocacy Toolkit is coming out next month. So again, we'd ask you if you're interested in downloading that and getting involved. Next slide, please. So a movement is only a movement with people behind it, and the strength of NOHep really relies on its community. we're really thankful for this opportunity to discuss a little bit more about what NOHep is and what we're doing. And it's not we, it's us. And I think that's just a really important point to make, that it is a community that is growing. It is a community that is adapting. And we really would encourage you, if possible, to incorporate it within your activities. Use it the way you want to do it. It's not owned by the World Hepatitis Alliance. It's not owned by WHO, CDC, or anybody. It's owned by you. So we definitely encourage you to get involved, share your experiences, learn from others. And yeah, we can only the elimination of viral hepatitis won't be achieved unless we do it together. So thank you very much for the NVHR and Happy United for allowing us to speak today. I think on behalf of myself and Sue, it's been a real pleasure. And we really look forward to seeing how the US will continue its action to the elimination of viral hepatitis. Thank you.
Okay, hi everybody. This is Heather Lusk, and I am the co-director of Hep Free Hawaii. And my co-director, Thaddeus Pham, is there on the front line. This is the North American contingent at the World Hepatitis Summit last year. And we're really thrilled to have been a founding member of Hep B United. As Tina mentioned, I'm currently the acting chair of NVHR, and we're also very proud members of the World Hepatitis Alliance and the NOHep campaign. So I'll be talking a bit about Hep Free Hawaii's new strategic plan, which is to support viral hepatitis elimination in Hawaii. Next slide, please. So Hep Free Hawaii was founded about 7 years ago with myself and Thaddeus. It's a public-private partnership. I am the director of a nonprofit who's a fiscal sponsor of Hep Free Hawaii, and Thaddeus is the viral hepatitis prevention coordinator at the Department of Health. So together we're able to really balance his expertise and connection globally and within the Department of Health, though he can't advocate and I can. So we really together try to find a balance. We're a coalition, as I mentioned, of over 80 agencies, and our biggest impact, because we're mostly a working coalition, is around integration. And the three things we really focus on the most is awareness, access, and advocacy. Next slide, please. So this is just showing you, again, that we have a medical advisory board that supports myself and Thaddeus as co-directors, and then my personal board of directors of my agency, since we're the fiscal sponsor, also has a fiduciary oversight. And then again, we have one staff who's a hepatitis coordinator, and then some educators that do hepatitis B education in the Micronesian community, but most of the work is happening at the partner agency level. Next slide. So for those of you that know much about Hawaii, you can understand why we are focusing on both hepatitis B and C, especially liver cancer. We have the second highest rate of liver cancer in the United States. And we have obviously a very high rate of folks from Asian Pacific Islanders and Native Hawaiians. Next slide. So the three major populations that Hep Free Hawaii focuses on is hepatitis B for our Asian Pacific Islanders and Native Hawaiians. Those baby boomers born 1945 to 65 for Hep C. And then, as many of you know, we're now having a syndemic with the opioid, I call it opioid opportunity, not crisis. But we're seeing more Hep B, unfortunately, in this population, in addition to their existing risks for hepatitis C. Next slide. So again, for most of you that have been to our beautiful state, we're the most remote archipelago in the world. And one of the reasons why we're particularly so excited about the NOHep campaign and involved in the World Hepatitis Alliance is that we have a very multicultural community. And as you see here, we have a significant amount of Asian Pacific Islanders and Native Hawaiians that live in Hawaii and therefore are a particular risk for hepatitis B. According to our last census, 17% of the folks in Hawaii were born in a country that had a high rate of hepatitis B. And not only that, but because of the long-term history of folks here, we are a rural island, so there's a lot of intermarrying and different pieces. Even some local data has indicated even our Caucasian population in Hawaii has a much higher rate of hepatitis B, according to Dr. Sai, one of our hepatologists, because of the kind of long history and intermingling of all of our cultures. Next slide. So these next few slides, I'm actually not going to focus on too much. We have a lot of experts in the room, but we do a lot, just like any other community, even though we are predominantly Asian and Pacific Islander in Hawaii, that is the largest ethnic group, there's still a lot of silence and stigma around hepatitis B. And I think it's particularly challenging for Thaddeus and I and the partner agencies, given that this is such a high, such a big issue in this community. We've struggled dramatically to try to get it addressed within the medical home and within the systems of folks that serve our API and Native Hawaiian community. Next slide. So you guys know about baby boomers, so we're trying to focus on, we have an aging group here, we call them kapuna in Hawaii, but 1 out of 6 people in Hawaii are in this age cohort that should be tested for Hep C. And like many communities, we don't have high rates of screening and or identification, unfortunately. Next slide. So because my program is also the statewide syringe exchange, we've done a lot of integration of both hepatitis B and C and to work with people who use needles. And as I mentioned, we're starting to see, unfortunately, even despite our vaccination efforts with Hep B, some acute Hep B in that population, which is really just breaks my heart when we have this access to a vaccine, or we have a vaccine, that we're seeing these outbreaks of hepatitis B. Next slide. And then just recently, our youth risk behavior survey for the first time asked about prescription medications, and we found a much higher rate than we expected in our schools. This just happened in last year. So we're starting to do some outreach to young people, which we were already doing for Hep B, and really going into schools for Hep B and talking about, not necessarily for them, but they could be ambassadors to their parents, grandparents, aunties, and uncles who might have been born in areas where there was more endemic Hep B. So we had a whole piece in the schools for that. We weren't really addressing Hep C as much in schools, and now we're starting to integrate that more in because of some of this data coming out that our youth are experimenting with opioids. Next slide. So Hep-Free Hawaii's main philosophy is really looking at intersectionality. Given that, like many areas, we have very few funded positions or funded dollars going to hepatitis efforts. In order to eliminate hepatitis, we need to leverage every opportunity we have of where hepatitis might intersect with other issues. So we've done that around, for example, here in Hawaii, there's the Compact of Free Association, which some of you may know is because of the damage that the U.S. government did to many Pacific jurisdictions. So then they made a commitment that folks from certain areas, Micronesia, for example, could come into the United States and get access to healthcare, and then came back later and said, oh, well, actually, no, we're actually going to limit your access to what you have, what kind of medical care you have access to. So we've gotten involved in that issue because of the high rates of hepatitis B in the Micronesian community. Or another example is we're working with, the AARP around the baby boomer issue. So trying to find folks that are already doing work and really link hepatitis to the issues they're already doing, and trying to find little mini research projects, which I'll mention a little bit later, in order to develop data that shows that this intersectional framework is an effective way to eliminate hepatitis. Next slide. So in addition to drug user health, I mentioned we're doing a lot around wound care and overdose prevention because those are issues that people who use drugs struggle with. One of our most exciting new projects that we're in the process of evaluating is a street-based wound care project where our hepatitis coordinator partners with the nurse and has gone out, one, because in late-stage liver disease, whether it's Hep B or C, wounds can be more common as the liver starts to break down. But more importantly, we have found that folks that are on the streets don't always have access to these services, and we have identified both Hep B and C through our connections with our wound care nurse on the street that I don't know otherwise we would have been able to connect. Another big win for us recently is that we got a Prevent Cancer Foundation grant to address Hep B, and that's the first time that we've been successful in being able to articulate how important it is for our Hep B efforts in order to prevent liver cancer. So we're working with several of our community health centers to do more hepatitis B care coordination and screening to really, again, using that as a way to prevent liver cancer. Next slide. In addition to talking about our intersectionality and how we can use any door that might be around another issue, but be able to link hepatitis to it. We really believe in our relationship capital. So what that means is that we really work as hard as we can with our coalition partners to support them in getting hepatitis-related funding, to taking our strategic plan to eliminate hepatitis in Hawaii and help them for their area. So for example, because we're an island state, there's actually a really interesting opportunity to look at eliminating hepatitis, for example, on Kauai. So we helped somebody on Kauai get a hepatitis B grant in order to try to eliminate Hep B on an island that has 50,000 people. So that seems like a more doable opportunity to screen and then get folks vaccinated at a high level and see if we could really do that because of the being water around the island. There's actually an opportunity that we could get ahead and eliminate it there. The other piece that we really do is try to highlight in any of our coalition meetings all of the great work our partners are doing, and as much as possible support them through funding, letters of support, trainings, but also really ask them to continue to let us know in ways that they're able to make a difference and continue to inspire them, because as you all know, it can be a very lonely world trying to advocate for these diseases and liver health when there's so many barriers and stigma in our way. Next slide. So one of the biggest communities that we've really wrapped around has been the Micronesian community. Some data indicates that as many as 1 in 8 people in some of the Pacific jurisdictions have hepatitis B. So we have Kenson Alec, which actually we have a video of him on our website, is a hepatitis B survivor and a liver transplant recipient. And so him and his wife, that's Rensley there in the picture, they do in-language education on hepatitis B and connect folks, whether it's through faith-based in churches, doing it out in communities. And then we're really thrilled that we brought Rensley and Kenson to Hepatitis on the Hill one year so they could tell their stories and advocate directly with our policymakers. Next slide. Like many of you, we're trying to do more integration into community health centers. So this is our, both with hepatitis B and hepatitis C. So we do this in every way from supporting, for example, on our website, we have a great form you can download that actually has the codes for insurance for billing for hepatitis B screenings and vaccinations and hepatitis C screenings, so folks can take that to their primary care doctor. We don't necessarily do screenings, but we do a lot of ways to link people to their medical home, and particularly around the language access again, because we have particularly unique languages, mostly Pacific Islander languages that there weren't existing materials. So we now have in-language in Tongan, Samoan, Chuukese, Marshallese, and some other languages to help reach out to that community for hepatitis B. Next slide. So this just shows you our Hep B project at Kalihi Palama, and we had a 6% positivity rate, which is I consider to be very high, considering that we're part of the United States. Many people don't see a 6% prevalence, and that really showed us that we have a lot of work to do. The challenge here was that even though we had that positivity, it was really hard to get the care for folks at the health center. And so now, as I'll talk about in a bit, we're really moving into how do we build champions within these health centers to actually treat and manage the diseases once they identify them. Next slide. This just notes that we're also doing work with our pharmacies to do Hep C tests. We can't wait till there's a rapid Hep B test to do the same. Next slide. And as I mentioned, we also have hepatitis care coordination this is our Hep C data, but we also have hepatitis B care coordination that will help navigate anybody with hepatitis B or C through the systems. Next slide. So the last few things I want to note is advocacy, that's why we're so proud to be part of the NOHep campaign. As I mentioned, Thaddeus, even though he's so fabulous, cannot advocate as a state employee. So I'm able to do that. For example, we got a D+ on the state of access report card on hepatitis C. So we're working on some language to our Medicare system. We're working with, again, trying to support having more testing for hepatitis B and coverage of vaccines. Like many of you, we've really struggled with our 317 program being cut and not having access to hepatitis B or A. Many of you know we had a big hepatitis A outbreak, and the silver lining of that is it did support many more people in getting vaccinated. Next slide. So since we're a proud member of NVHR and Hep B United, we take all of the alerts and opportunities for people to go on webinars like this, as well as advocate to our network. and really are proud of many of our folks signing on and going to Hepatitis on the Hill and getting more involved and making systems changes. Next slide. So the last thing I want to mention is we just finalized our brand new strategic plan. It's available on our website and just released it a couple of months ago. It is aligned with all of the other elimination efforts, but has some cultural implications for Hawaii. And our three major goals, as you see here, is how do we build our infrastructure to be more sustainable? Our big one is how do we identify champions and support those champions, particularly in primary care and FQHCs. I gave an example of Kalihi Palama. They screened for Hep B, but didn't really manage those patients very well because of capacity. So working with Dr. Sai and our other liver specialists to train and support. I think you all know that once you find a champion in a setting, that's really what often you need to make the change within the agency or within the clinic to embrace hepatitis. And then lastly, like anywhere, is to increase access. So please feel free to go to our website to become a partner agency. We have partners across the country and the world, not just here in Hawaii, and really appreciate the opportunity from NVHR, Hep B United, and the World Hepatitis Alliance to be part of the webinar today. Thank you so much.
Thank you so much, Heather, and thank you to you, Tara, as well, and Sue. So now we'll move on to our next case study of Alaska, and I'll turn it over to Lisa. Oh, Lisa, you might be on mute.
Can you hear me now?
Yes, you're good to go.
Okay. We just pulled up the camera here because I wanted to say thank you for letting me speak today. And with me today are the heart of the Hepatitis B Alaska Native program here in Alaska. Two registered nurses, Sue Nagus and Mary Snowball, and they have been caring for Alaska Natives with hepatitis B going back to the 1980s and 90s, and they ensure that Natives get the care and follow-up that they need. And I must mention that Dr. McMahon, our medical director who started this program and continues to lead it, is at one of our rural field clinics today, and unfortunately will not be able to join us today. So I'm going to go on to the slides. Next slide. Okay, so you can go to the next one then. So here are the WHO goals for hepatitis B elimination. I'll be talking about the Alaska experience to show that these goals are achievable. Next slide. We know that universal vaccination is one of the most important tools for preventing hepatitis B transmission. It will reduce transmission at birth from hepatitis B surface antigen positive mothers with high viral load from 90% down to less than 10%. And adding hepatitis B immunoglobulin to this further reduces transmission to less than 5%. On top of that, if you add antiviral therapy to mothers with high viral load or E antigen positive, then you can theoretically completely prevent transmission. The other steps required to reach global elimination of hepatitis B include screening and detection of all persons with hepatitis B and treating and curing all infected persons. For the sake of time, cure of hepatitis B won't be part of this discussion. Next slide. So what happened in Alaska? Starting in the 1970s, studies found that high rates of acute and chronic hepatitis B infection in Alaska Native people was occurring, especially in Western Alaska. This was the only identified U.S.-born population with endemic hepatitis B. Also in Alaska, there were high rates of hepatocellular carcinoma, HCC, occurring in those infected with hepatitis B, including children. Subsequent studies of hepatitis B genotypes in Alaska Native people found genotypes A2, B6, C2, D2 and 3, and F1. Perinatal transmission was a major route of hepatitis B transmission in northwest Alaska, where genotype C predominated, and horizontal transmission through open cuts and scratches was the main route of transmission in southwest Alaska, where other genotypes were found. Next slide. Starting in 1980, universal screening of pregnant women was instituted at Alaska Native Medical Center in Anchorage and at the Bethel Native Hospital in Western Alaska. Infants of hepatitis B surface antigen positive moms received 3 doses of HBIG starting in the delivery room and at 3 and 6 months. Then in 1982, the hepatitis B vaccine started at 3 months of age, and the first dose of vaccine along with HBIG was given to the newborns of surface antigen positive mothers. And hepatitis B vaccine was continued at 1 and 6 months, and then subsequent doses of HBIG were dropped. Starting in 1983, universal statewide hepatitis B vaccine was instituted, and starting at birth, and HBIG was given to the newborns of Hep B surface antigen positive mothers. But despite the vaccine and HBIG given right at birth, in 1990, there were 2 infants identified of E antigen positive mothers who had acquired hepatitis B and became chronically infected. So then, starting in 1991, antiviral therapy, initially with lamivudine, was given for pregnant women who were E antigen positive, along with the vaccines at birth and HBIG, and then more recently, tenofovir. Next slide. So with the launch of the Alaska Native Hepatitis B program in the early 1980s, and the start of the universal hepatitis B vaccines being given at birth, between 1983 and 1988, 53,000 people were screened for hepatitis B, which was 3/4 the Alaska Native population and 90% of those in the endemic areas of Western Alaska. Catch-up vaccination of children and adults was done during this time. Next slide. The 5-year screening program was done in villages across Alaska, but focused on Western Alaska. If you're not familiar with Alaska, there were and still are very few roads. Roads on this map are noted in red, and so you can see that there are few roads in Western Alaska. Most villages are reached by plane or boat or snow machine in winter. And next slide. Since the start of the hepatitis B program in Alaska Natives, there have been no new cases of acute hepatitis B in Alaska Native children since the mid-1990s, and no more Alaska Natives under the age of 20 with chronic hepatitis B infection. Rates of liver cancer went from the highest reported in the world to 0 in the mid-1990s. Next slide. So this shows the number of children found with chronic hepatitis B in 1988, which was over 450. And 20 years later, in 2008, Alaska Native children had chronic hepatitis B. Next slide. And here's the rate of liver cancer in children falling from a high of 3 per 100,000 to 0 in 20 years. Next slide. And so here you can see the impact of giving universal hepatitis B vaccination around the world. This has reduced the prevalence of hepatitis B in children from as high as 15% in rural China down to less than 2%. And as shown here, it's been done in all of these countries and in Alaska. Next slide. So it is important to note that there will be a 3 to 4 decade lag time in overall reduction of liver cancer incidence once newborn vaccination programs are introduced. And during this time, you need to identify all those with chronic hepatitis B and link them to care and antiviral therapy as appropriate. Identify those who meet guidelines for HCC screening and do regular surveillance for hepatocellular carcinoma, and currently in men with chronic hepatitis B over 40 and women over 50 based on guideline recommendations. Next slide. With that in mind, these graphs show the lag time between hepatitis B infection and the 30 to 40 years when the incidence of cirrhosis and hepatocellular carcinoma mortality exponentially increased. Next slide. Outside of Alaska, the majority of children and adults in the U.S. with chronic hepatitis B are immigrants or have immigrant parents or were exposed through close household contacts. Those at highest are persons who were born in countries with prevalence of chronic hepatitis B greater than 2%. These persons should be screened per CDC and AASLD guidelines and if positive, linked to care. And those who are surface positive need lifelong monitoring and antiviral therapy if they meet AASLD guidelines / guidance. So this map shows the geographic distribution of chronic hepatitis B infection. It is a little bit dated. It was before universal infant vaccination was. Areas in red had hepatitis B prevalence greater than 8%. Those in yellow had a 2 to 7% prevalence, and those in green less than 2% prevalence. Next slide. This map was prepared for the World Indigenous Peoples Viral Hepatitis Conference, which was held here in Alaska last year. It shows the change in prevalence of chronic hepatitis B across the world based on more recent epidemiological evidence and following the adoption of universal vaccination programs. I'm sorry, it is a little harder to see on the screen. The lightest areas have less than 2% prevalence. The two gray shaded areas have the 2 to 8% prevalence, and the darkest areas have prevalence greater than or equal to 8%. There has been progress made across all continents, but it is important to note that there remains pockets of endemic hepatitis B, even in countries with overall prevalence less than 2%. And this underscores the need for continued screening for hepatitis B, even in countries with low prevalence. Next slide. Moving on to HCC surveillance, the AASL and screening with ultrasound, Asian or Black males 40 and older, and Asian females 50 and older, and those with a family history of HCC. Also persons with Delta virus and those with cirrhosis. HCC surveillance is cost effective if the incidence of HCC is greater than 0.2% per year. And from the Alaska Native Liver Disease and Hepatitis Program data, there was a retrospective analysis of HCC surveillance using AFP from 1983 to 2012 among the 1,083 Alaska Natives who were identified as chronically infected. The SEER NIH Cancer Registry was also queried for this analysis. Next slide. Here are the demographic outcomes by genotype and the number of years of follow-up. Overall, the median follow-up was 29.1 years, and this analysis showed that HCC and genotype F disproportionately affects the young, and HCC and other genotypes affects older persons. Next slide. Using odds ratios, the analysis showed rates of hepatocellular carcinoma increased with age. Men have a 1.83 times higher risk of HCC than women. And when comparing genotypes B and D to A, C, and F, the 4 times higher risk of HCC for genotype A, 8 times higher risk in genotype C, and a 14.6 higher risk in genotype F. Next slide. A closer look at Alaska Native genotype F, which is the type that is found in Central and South America. The incidence of hepatocellular carcinoma is significantly higher in genotype F than all other genotypes found in Alaska. Next slide. So in conclusion, the experience of the Alaska Native Hepatitis Program underscores that all pregnant women should be tested for surface antigen and if positive for HBV DNA. All newborns, regardless of mother's hepatitis B status, should receive hepatitis B vaccine starting at birth and 2 to 3 more doses in infancy. New hepatitis B surface antigen positive mothers should receive hepatitis B immune globulin and the hepatitis B vaccine at birth in the delivery room or no later than 4 hours after delivery, plus the remaining hepatitis B doses in infancy. Hepatitis B surface antigen positive mothers, HBV DNA levels greater than 200,000 should receive antiviral therapy in the 3rd trimester and for 4 to 6 weeks postpartum. And all persons in the U.S. born in a country endemic for hepatitis B should be screened for hepatitis B surface antigen and, if positive, linked to lifelong care and treatment. Next slide. So here is our program's website, anthc.org/hep. And next slide. I just end with a photo of North America's highest mountain, which is Denali at 6,190 meters or 20,310 feet, which is we can see outside our window on a good sunny day here. Next slide. Kuyana, thank you.
Thank you so much, Lisa. So we'll now begin the Q&A portion of our webinar. Just a reminder, we do have a couple of minutes time for a few questions. If you'd like to submit a question, please feel free to do so now via the question box on your control panel. So we did have a few questions and comments that came in during the presentations, and I will go ahead and take those now. The first question, and this probably is for you, Tara or Sue, of the 194 countries that are on track, nine of the 194 countries, 9 are on track to eliminate hepatitis C. It is important to highlight that this is not elimination of Hep B. Which countries are on track to eliminate hepatitis B?
Do you want me to take this one? I'll go for it anyway. Thanks for that question. It's a very good question, and it's one that we're at the World Hepatitis Alliance are trying to answer. We have received the data is only available for C now. We use those 9 countries on track are taken from the Center for Disease Analysis Foundation, which is based in the US, and it's the Polaris Observatory, if you're not aware. We'd suggest having a look at it. We're hoping that this year we'll get updated figures for hepatitis B and understand which countries are on track for hepatitis B, and we hope to have that over the next couple of months. So once we get that, we'll share it with you and with the audience, and we'll be making a big announcement around it. So for now, we don't have that data, or it's not available as far as I'm aware on a global level.
Thank you, Tara. And then a comment from a participant from Africa who is interested to partner with the NOHep campaign. Just a note for you, Tara, and I don't know if you want to comment on ways in which they could participate.
Yeah, absolutely. So the first step in how to participate is just simply logging on to www.nohep.org and signing up. It's very simple, and there you'll start receiving information from us on ways you can take part. Every month we send out our NOHep news, which is our monthly newsletters with key activities and updates in the agenda or in the landscape. And alternatively, you can get in contact with us. It's connect@nohep.org. If you have an idea or an initiative you'd like to discuss with us or else you can go to our resources page, and you can download toolkits on how you can build a NOHep movement in your country. So lots of ways to do it, but we would really encourage as many people to get involved as possible.
Thank you. And I know we're running out of time, but I did want to touch on one more question, and I'm combining two that I received related to prevention of mother-to-child transmission. You know, an individual did ask, what are we doing to address the need for the birth dose and the prophylaxis as we're starting to see Hep B being a huge problem in Africa. And then the individual from Africa commented that there have been really great strides and wonderful work to eliminate hepatitis B in Alaska and via perinatal transmission. And they're interested to know what can they do in Africa, and how is there a training for nurses or practitioners or an internship, and how can they partner so that they can work on eliminating hepatitis B and working on perinatal transmission in Africa as well. So I don't know if Lisa or Tara or Sue, you want to comment on that?
Would you like to?
Or Lisa, if you want to provide any advice on?
Oh, you couldn't hear me. Okay, sorry. Yeah, so I was saying I'm sorry that Dr. McMahon is not with us because he just came back from Africa last month, and he was sharing that I guess there's going to be those small platforms available to run HBV DNAs very quickly within a couple hours, so that those could be in a lot of hospitals there. And the other thing is, though, if you know that somebody is E antigen positive before birth, it doesn't hurt to go ahead and do the antiviral therapy in the third trimester, so that you know, they're protected that way. And then, of course, getting the HBIG and vaccine at birth.
Thank you. All right, and we are out of time, but I did receive a few great comments and resources. I just wanted to note that the Polaris website, a few people said, summarizes the countries that are on track for HBV 5-year-old surface antigen, Hep B surface antigen prevalence elimination targets. So we can also send that out after the webinar. But I wanted to go ahead and close out and let you know how you can contact us if you have any further questions. Here's our contact information on our website. I want to thank Tina, Sheila, and NVHR so much for partnering with us on this webinar, and the World Hep Alliance, Hawaii, and Alaska for sharing the great work that you all are doing to eliminate Hep B and C globally. As I mentioned again, please feel free to submit questions to our email if we weren't able to take them today, and look out for a survey after the webinar so that we can get feedback from you. Thank you again, and have a great rest of the day, everyone.